So we did the cone after Stein when she was about 2 years old. And imagine that you need to put a shunt. But no, she was 88 to saturation and then progressive improved over time. So it's amazing how, if you have a low pressure, especially have a low pressure in the pulmonary artery, low pulmonary vascular resistance, well-developed pulmonary arteries, the RV worked very nicely. And we are very interested in that because when we had a bigger heart to start with, and then many times they don't come back to normal. So we have a large incidence of dilation of the right ventricle and dysfunction. So this might give us idea for other solution in the future, and we are working on that.
Thank you very much. I'm just catering to the people online. So we had one question, just scrolling up here from Dr. Kamal out of Pakistan, who has done several cone procedures, primarily in older patients, 15 to 50 years old, and he wanted to know whether you routinely add autologous pericardium to augment the leaflets, or only in specific situations where the tricuspid valve leaflets are deficient, whether you treat this with glutaraldehyde, and what the long-term results of valves who had these pericardial patches are.
We are evaluating those patients now, and that will be presented at the end of the month in one meeting. And we used in around 40% of the patients, we use some fresh autologous pericardium to complete portion of the proximal part of the septal leaflet, not the distal portion. And then those patients are behaving the same way as the other patients where we didn't use the patch. Actually, we saw some decrease of need for reintervention in those patients. Even being a very small number of reintervention that we had less yet in those patients that we used the patch, but we used in 40% of our patients some patch augmentation, but restricted to a small area of the cone. That's data from Pittsburgh, not from our experience.
And I also see in the chat they asked you to come to the podium because you're not on the video. So if you can move here as well. I've used the microphone to read the chat. So there's another question from Dr. Omran from TGH for what your criteria are preoperatively to select a tricuspid valve for cone repair, or is there any contraindications of patients where you would suggest not to do it?
Yeah. So for newborns that had Ull's anomaly, when we don't have any mainly we don't have any muscle in the right ventricle wall, that would be the only case where we would not offer the cone after stents. And for older patients that has already severely compromised left ventricular and right ventricular dysfunction, those patients would benefit more from heart transplant, or in some case just tricuspid valve replacement. But it's a very rare situation where we are not able to offer the cone repair. Do you have any other?
Yes. One concern we have is when you have a linear attachment of the anterior leaflet, extreme rotation and dilation of the outflow tract of the right ventricle. So those patients, we are very concerned about their V function afterwards. So if we have an older patient, like adult patient, in that situation, when we release the the valve, mobilize the leaflet, you have ballooning of the anterior leaflet of anterior wall of the right ventricle, and those patients tend tend to get heart failure in the future, I mean, dysfunction of the right ventricle. So we think in that situation, a valve replacement might be a better choice, but we are not sure about that, but makes sense. I mean, theoretically. So, so we never turned down a patient because of the valve, except for the one who had the problem with the myocardium. And it was a patient who had, together with the Ebstein anatomy, it had we didn't see much myocardium in the RV, but we had to operate because the patient had a pulmonary vein stenosis. So we repaired the pulmonary vein, and then we took a look at the valve. The valve could be repaired, but the vent could not respond to it. So we closed the valve and prepared the patient for a single ventricle pathway.
There's one more question online, and I'm not sure if there are questions out of the audience. Sorry. I can probably ask that question out of the chat first. Might be relatively quick to answer. When would you consider adding a BCPS after the cone?
A BCP?
Yeah, Glenn.
Usually when we have severe RV dysfunction and elevated the right atrial pressure, so we consider adding a gland, but it is a very small number of patients, and that we have done that. So basically, that's it.
Yeah, if you, I want to answer this question also talking about another concept that most of the patients have RV dysfunction initially. So, contrary to some group that don't close the SD because they close the SD, we we don't close it in a usual manner. We do a valved closure. We kind of reestablish the valve mechanism for the foraminal valve, and that so once the RV improves, that will close by itself, like the newborn. In some cases, you have to come back and put a device to close it after the RV recovered. For because of that, we use in fewer patients the Glenn procedure associated to the cone repair. But nowadays, we are concerned about RV dysfunction more than before when you look at the results in the long term. And we are more prone to use a little more than we used to be. And but anyway, we have seen patients with the gland and a bad dysfunction. And then you have to pay attention to the pulmonary valve as well. If we have any pulmonary regurgitation, we should repair it, decrease the annulus a little bit, especially in case of functional pulmonary valve regurgitation because of dilation of the outflow tract of the right ventricle.
Thank you, Osami.
Yeah, thank you very much, boss, for fantastic lectures. We have learned quite a lot. I have a question about more elective patients. So obviously you're both in this consensus sentiment from this year, talking about cone reconstruction and timing of reconstruction. So you mentioned that elective patient, let's say you have a severe tricuspid regurgitation, but patient are relatively stable, the optimal timing to do the cone reconstruction is 3 to 5 years of age. Would you agree to that? Or if the patient are followed in your institution from birth, for example, would you consider repairing earlier than 3 to 5 years based timing?
Yes. So knowing the natural history of Ebstein's anomaly, we know that most of the patients at age 40, they will start having arrhythmias and due to dilation of the right atrium and the right ventricle. So it's a progressive process. So if the patient, like in the expert consensus that we help to wrote, we decide like if the patient has severe regurgitation, dilation of the right atrium or the right ventricle, they would benefit in places where it's there is expertise on doing the repair of the valve to proceed with the repair. Um, and the reason for that is to prevent the continuous process of the Ebstein's anomaly. And some patients, we notice that mostly teenagers, they have a normal exercise capacity, but having severe tricuspid regurgitation and dilated heart, we still offer the operation to them. And later on, they relate to us that they didn't know what was normal. So they are feeling much, much better. So the goal of the con repair is to improve the forward flow. So it's very hard to evaluate the function, the real function of the right ventricle because of the tricuspid regurgitation. When we repair the tricuspid valve, you automatically decrease the regurgitant fraction. The afterload for the right ventricle is elevated. It's the same as in the mitral valve. When you decrease the mitral regurgitation, even the ejection fraction tends to be lower, but the forward flow to the semilunar valve will increase. So that's the reason we decide to do the repair. And also the hormonal spurt, the growth probably can have some effect in the myocardium. So that is the reason we decide to do in earlier patients if there is a good chance to do the repair, not the replacement.
Mm, I think we answer everything. Just from our own experience in Brazil without ECMO, anything, a long time ago, now we have everything. The mortality rate was much higher for the adult. Like Carpentier also experienced that type of thing when he introduced his technique. And I think when we do younger patient, we operate even except for newborn. After 3 months of age, we have never lost a patient in the hospital time, and that is already something important as far as doing the operation earlier on. But we are studying. This is something that's open to be studied, and especially if you have a bad anatomy. For example, if you have a very rotated valve, you take down the leaflet a lot, then immediately you have a bad ventricle and an enlarged right ventricle. And that can persist for many years. Sometimes they improve later on, sometimes not. But most of those patients have no symptoms, and that's interesting. So the way to evaluate that to maybe should change because when you start with a large diastolic volume and then you calculate the ejection fraction, it will be low because of that. It doesn't mean that the cardiac the right ventricle output is small. I mean, sometimes it's enough. So maybe you should measure other things, measure the cardiac output itself, or measure the velocity in the pulmonary valve, so and the stress test, and so on and so forth. So uh, sometimes the patient is doing very well with a bad ventricle and look bad ventricle, and people is very concerned, but they survive. They go, like the first patient we did took long time to improve the right ventricle, and I showed that the image 25 years later, the ventricle was reasonable, and she's doing fine.
Any questions out of the audience? There's one follow-up questions on the one that I just took out of the chat on the BCPS after cone is if you do BCPS in an older patient, how well do they usually tolerate competitive flow pulsatile from the PA versus the BCPS? And do you manage that any differently?
So if there is reversal flow, that means that we need to take down the gland, not to add the gland there. Like this week, I did a gland take down because the right ventricle function was good, and the patient, 6-year-old, had headaches, and there was reversal flow by the transesophageal echo in the gland. So that's a reason to take down the gland. And like Jose said, we can open a small ASD to allow right or left flow to prevent low cardiac output. I don't know what he was asking for.
Yeah, the attendee is also referring whether you think of banding a proximal RPA to increase BCPS flow, for example.
You mean when you do the yeah, some people there's the gland and at that same time cause a little stenosis in the left, in the right, actually, pulmonary artery, the origin. Uh, I have advised someone to do that, and it had worked well because it's too pulsatile, and then kind of isolate the RV pumping to the left, and then the the blood from the upper body going only to the right side, the right pulmonary artery. But the problem with that is that then that side doesn't get the liver factor. So in the long run, you can develop collateral.
AVMs.
Yeah, AVMs actually, yeah. Yeah, pulmonary fist, arteriovenous malformation, and become cyanotic.
Thank you very much. I think that concludes the session. I just can say thank you very much for giving us some of your expertise and insight. Quite impressive what you've achieved over a long career already. Okay, thank you.
Thanks so much. It was a pleasure.
And there's coffee.
Question for the home repairs in your older Ebstein patient. Do you ever have calls to do any kind of ventricle application?
Yeah, no, we do. Ventricle application, everybody.
Okay.
Yeah. But now what we do, so the lateralize, it's same wall, we always do. We do that in 90% of the patients.
Okay. And
When
a
we
linear
do
application inferior.
vertical, like vertical, like Carpentier described.
Yes. Okay.
The only, but when we do the stern, then we don't do it.
No, because the ventricle is small. Yeah. Thank you. Very nice to meet you. Very nice to meet you.
Also, we don't have presentation.
No.
Okay, right.
All day is coffee.
Okay, the coffee. Keep people
All right, good afternoon, everyone. Welcome back from the break. My name is Mark Friedberg. I'm one of the cardiologists here at Sick Kids. And after what's been a really fantastic and interesting day, we're going to continue with a session dedicated somewhat to imaging and somewhat to physiology. It's my pleasure to introduce our first speaker, who's going to talk about echo evaluation of the tricuspid valve and right ventricular function, Dr. Andreea Dragulescu. And Andreea is a good colleague and friend who trained in Romania, and I think did afterwards subspecialty training in France and in London a little bit, and came to us initially as a research fellow, and it's been a pleasure to watch how Andreea has really grown and become one of the leaders in pediatric echocardiography on an international scale. And Andreea focuses on pediatric echo with advanced imaging techniques, 3D echo, and also now leads the pulmonary hypertension service, among many other hats at Sick Kids. So Andreea, please go ahead.
Mark, thank you very much for the very kind introduction. And thanks the organizers for the invitation to speak in this amazing symposium on Ebstein. It's a great honor to be alongside the world masters in Ebstein. I will talk today about the tricuspid valve and right ventricular function in this pathology. I have no disclosures. There will be some overlap with the previous talks that you have seen, but just to introduce a little bit, you already know that Ebstein is an anomaly that affects the whole right ventricle, including the myocardium. There is a right ventricular myopathy, actually a biventricular myopathy. You will hear a bit more about the left ventricle in the next talk. It is characterized by a failed delamination of the septal and inferior leaflet, sort of a spiral defect of the tricuspid apparatus. The anterior leaflet is variable in its degree of dysplasia, and the hinge point usually remains at the AV junction. And it is a spectrum of disease with regards to the degree of displacement, the degree of leaflet and caudal dysplasia, and the extent of failed delamination. The diagnostic workup is based on echocardiography to delineate the valvular anatomy, the degree of tricuspid regurgitation, the ventricular function, and the associated anomalies. Cardiac MRI is indicated in preoperative planning, EP assessment, especially if history of SVT or accessory pathways, more on it tomorrow in the arrhythmia session. And exercise testing, a 6-minute walk test or a CPAT, it can detect occult exercise intolerance and the presence of desaturations with effort. I will focus mainly on the use of echocardiography for the tricuspid valve and right ventricular imaging, which is very important. As the surgical indications, according to the current AATS expert consensus, surgery is no longer reserved only for symptomatic patients, but asymptomatic ones as well, those with severe regurgitation, moderate enlargement, and favorable valve anatomy. And imaging finding will guide the earlier interventions. So what do we do with echo? We look at the apical displacement of the septal and inferior leaflets, the tricuspid annular size as Z-score, the leaflet morphology, the dysplasia, thickened, if they're thickened, if there are fenestrations, if there are multiple orifices, short chordae, underdeveloped papillary muscles, etc. The mobility, the tethering, we look at the degree of TR and or stenosis if there is, knowing that the regurgitation can be sometimes difficult to quantify given the compliance of the atrialized right ventricle, as well as the multiple regurgitation jets that are often in different planes. The pulmonary stenosis or pulmonary atresia, functional or true, the presence of pulmonary insufficiency can differentiate functional from true pulmonary atresia, and I will show an example. On that, the direction of the presence of PDA, the direction of flow in the PDA can help determine adequacy of pulmonary valve antegrade flow. And the presence of an atrial communication and direction of flow at that level can be an important marker as well. In neonates, it is important to look for a surgical shunt, circular shunt. You've heard about this already, and I will come back with an example. And the detection of this, recognition of this, it will affect the management of these patients. Now, keeping in mind that Ebstein is not only a disease of the tricuspid valve, but a myopathy, a biventricular disease, we have to incorporate the assessment of the right ventricle size and function, as well as the left ventricle in our assessments. To assess the anatomic severity, for example, the Sellemeyer index, the chamber area ratio, was developed as an indicator of poor prognosis more than 30 years ago. This is the initial publication with their survival curve. Of course, it's not valid anymore, but just impressive how it could differentiate the prognosis at that time. So how do we assess the tricuspid valve? The standard views are nicely summarized in this review paper. Let's go a bit one by one. First, on a long axis, you can, in these views, we usually look at the anterior and the inferior leaflet and can also assess the several jets of regurgitation that often occur anteriorly as the orifice of the tricuspid valve is tilted towards the outflow tract. The short axis views at the level of the aortic valve, we see the anterior and the septal leaflet, and if we go down into the ventricle, we can appreciate the level where the displacement of the septal and the inferior leaflets are into the ventricle. So here at the level of the mitral valve, we see both those leaflets displaced. As we go further down towards the apex, we start seeing more valvular tissue at that level. The apical four-chamber view, and Shijun showed a nice example in his talk this morning, where depending where you cut your ventricle, you can see more leaflet, usually anterior, more septal leaflet anteriorly, and more displacement on the septal leaflet looking inferiorly or posteriorly. Also, you can locate the regurgitation jets in these views. And then the three-chamber view of the right ventricle, either from apical or from subcostal, where you see the inferior and the anterior leaflets. In the example above, significant tethering of both septal and inferior leaflet, but very mild regurgitation. While in this second example, despite a lot of valvular tissue, we have a large coaptation defect and severe regurgitation. These are very good views to use. I would say that in children, in neonates, the subcostal views in short axis can be very helpful because you can appreciate all three leaflets and have an en-face view of the valve, also detecting the location of the regurgitation jets. And in the same views, we can obtain 3D images. In this particular example, you can see the very large coaptation defect centrally between the three leaflets. A few more examples of 3D echo, as it's one of my things, as Mark mentioned. This is a milder form of Ebstein, where we have displacement of both the septal and the inferior leaflet. This is a view from the ventricle looking up towards the atria, and you see the septal anterior and neural leaflet with a fairly good coaptation. And on the right side, a view from the atria looking down. And on this right side picture, we practically cut the heart at the base of the heart at the level of the mitral annulus. And we're cutting part of the mitral valve out, while the tricuspid valve, you can appreciate it's way down into the ventricle where the leaflets come together and the coaptation happens. Also, in acquiring a good 3D volume, you can use multiplanar review and identify different spots of the valve, what happens with the valves. And here you see the intersection on the 3D of the two planes. We are at the septal inferior commissure, which is not really a commissure. The leaflets are fused at that point, and can see in the other quadrants how much the inferior leaflet is displaced on the right upper. The left lower, we see the septal leaflet, and then an on-pass view on the right lower image. Acquiring a color 3D, we can learn more about the location and severity of the tricuspid regurgitation. This is an example where, again, using the multiplanar review, you can appreciate the main jet of regurgitation coming between the septal and anterior leaflets. And again, moving your cursor within the three planes, you can exactly locate the origin of that jet. And with that, I want to go through two cases. The first case is a baby boy term, had a prenatal diagnosis of Ebstein. At birth, he presented with mild cyanosis, but overall clinically stable, as severe displacement of the septal and inferior leaflets. As you can see from the different images in apical four-chamber, you see that the septal leaflet goes all the way to the moderator band, and the subcostal en face as well. You see that the inferior part of the septum, as well as the inferior wall of the right ventricle, the valve is completely stuck to the wall there. The Puni valve was normal, and there was good antegrade flow on the Doppler profile of the Puni valve. The patient was followed in a different center and was presented as a 7-year-old for discussion for surgical consideration for surgical repair, because there was some subjective decrease in exercise tolerance, and echo studies in follow-up showed somewhat increased right ventricular volume over the last couple of years. He was accepted for surgery here, but after long discussions, the family decided to go to the US for repair. And where he, 3 years ago, he had a cone procedure with radiofrequency of the cavo-tricuspid isthmus ablation and ASD closure. And he came back for some follow-up about 2 years after the cone. We see here the reconstructed valve with only mild tricuspid regurgitation, a good coaptation of the leaflet prolapsing. The right ventricle remains dilated with decreased function, but overall a good result, and clinically the patient is doing very well. During the follow-up of these patients, we can use, again, 3D echo to assess the valvar reconstruction, the coaptation, and the presence or absence of regurgitation, and also quantify the right ventricular function with RV ejection fraction, which was still reduced here 2 years later. But again, good, clinically well, so good cardiac output. And a second case, another baby boy, this time a bit premature at 32 plus 3 gestational age, was had a C-section for decreased fetal movements. There was no prenatal diagnosis, and there was high drops. He required neonatal resuscitation, including epinephrine, chest compressions, positive pressure ventilation, and intubation. Due to persistent cyanosis, he was transferred from across the street here, and the early postnatal course was significant for high drops, respiratory distress syndrome, hypoxic ischemic brain injury, and he remained cyanotic, so we did an echo, and you can see that he had bilateral pleural effusion, he had ascites, and starting to look at the heart. There is a PFO shunting right to left. It's not working. It was working 15 minutes ago when I tried. Okay, well, I have to restart PowerPoint. I am sorry.
Just for the people online, where Andrea's just restarting her PowerPoint. We'll continue.
HDMI2. It's coming. All right, here we are. Sorry for that. PFO, shunting right to left, severe tricuspid regurgitation with a large coaptation defect that you can appreciate. And you can also see that the Puni valve is not opening, but there is pulmonary regurgitation. So functional pulmonary atresia. He was initially started on PGEs, but there was concern for circular shunt. As you can see here on the right side, the flow through the PDA coming into the MPA back into the right ventricle, and with a severe tricuspid regurgitation, typical circular shunt. So at this point, the decision was to stop the PGEs and just managed medically with a high FiO2. His clinical condition gradually improved after PDA closure. He developed one episode of atrial flutter that was treated with esophageal overdrive pacing with no subsequent episodes. And he was eventually discharged home and followed as an outpatient. This is an image of his valve on FAS as a neonate. The right ventricle was already dilated. There was a large coaptation defect between the leaflets with a very tethered septal and inferior leaflets. He did pretty well clinically, maintained SATs in the mid-90s, mid to low 90s, growing on his own curve. And around 3 years of age, he reached 12 kilos and had subjective mild effort intolerance. Heart was big. And when we look at the echo, his right ventricle was huge. There was an even larger coaptation defect between the centrally and if the regurgitation was severe at birth, it was massive now with the heart that the right ventricle and right atrium huge, and the left ventricle that was not feeling much, but still clinically he was fairly good. He was in view for the surgical discussion. We did a cardiac MRI, which showed severe TR, estimated tricuspid regurgitation between 78 and 83% of the flow going through that tricuspid valve, a massively dilated right ventricle with an RV and diastolic volume index at 300 and an ejection fraction of 48% and LV ejection fraction of 52%. He also had an EP study because of his history of atrial flutter, but it was normal, no inducible arrhythmias, and went for a cone repair here with a right atrial reduction and PFO closure. And this is his follow-up about 9 months after the surgery. He recovered well after the surgery. He was discharged home on day 4, post-op day 4. The RV 9 months later is pretty much normalized in size. There's trivial tricuspid regurgitation and very mild inflow gradient, average over several beats between 2 and 3 millimeters of mercury mean gradient. So very good result. And you can also see here on the right upper corner, his left ventricle much happier than pre-op. So when we talk about the post-op assessment, beyond the valve competency and the antegrade flow, long-term assessment of different functional parameters of the right ventricle is important. And beyond the visual assessment, which is practically our day-to-day, we do calculate the fraction error of change. For this particular example, it was 22%, so reduced. And we do right ventricular strain, which we follow up post-op, and we often see a gradual improvement as the ventricle remodels. And it's a good marker of remodeling. In some cases, we use 3D echo, as you've seen in one of the examples, but it's not very consistent with not all the patients get it. Depends who is reviewing in the lab and how much time we have to ask for it. There are other things to be considered, like left ventricular function will be addressed in the next talk, but also right ventricular electromechanical desynchrony, ventricular-ventricular interaction, and I'm sure Mark will touch on that in his editorial comments as he has published on the subject. And I know there's more work in progress. With this, I want to recap what we need to keep in mind and look after a cone repair. Coming back to this recent review, it illustrates nicely the potential complications of the cone repair, like cone dehiscence, myocardial infarction, RV plication dehiscence, RV thrombus, or cone stenosis. And I have to say that I was quite happy that I wasn't able to find any such examples in our database, other than some mild inflow gradients that seem to improve with time. Now, before concluding, I want to share a few slides that Isra shared with me on imaging fusion in the evaluation of AV valves. Thank you, Isra, for that. We do multimodality imaging to get to 3D models. You'll see more of that tomorrow. But just a brief overview from the image acquisition. We use MRI data or CT data and 3D echo data and put them all together, each keeping in mind that all these imaging modalities have different spatial and temporal resolutions, and we want to put them together. And we go from segmentation to volume rendering to computer-aided design to the actual fusion of the imaging and 3D printing of the model. There is a lot of imaging co-registration, temporal alignment, a lot of stuff going into the background, together with validations of the measurements that are done by echo and by cross-sectional imaging to make sure that what we get is pretty real, and to get to the clinical applications that Shijun has developed here for so many years now, and we all benefit from. And the clinical applications include Ebstein's. And this is an example of a 3D valve that we acquired, and then fused it into the cross-sectional imaging, and you can appreciate the movement of the valve within the heart. Surgical training is also done, and you will see this tomorrow afternoon. This is one of the models that has been printed and is available outside. So thanks again, Isra, for sharing these slides. This is the 3D print team. To conclude my talk, to say that Ebstein anomaly is a spectrum of disease. There is highly variable tricuspid valve morphology. It's an RV myopathy. So while we know that RV function is pretty difficult to assess in a normal heart, in Ebstein's it's even more so. Eyeballing is used, by quantitative measures can be added, each with their pitfalls to be aware of. RV ejection fraction by cardiac, by CMR or 3D echo can be obtained. It may not reflect myocardial function per se, especially in the setting of TVA TR. Pulmonary antegrade flow, LV filling, and ventricular-ventricular interaction may be as important as RV function. The cone procedure has improved the success of biventricular repair, with current indications aiming for earlier repair to improve long-term outcomes. and echo remains the main imaging modality. With multimodality imaging essential for accurate anatomical and functional evaluation, tricuspid valve morphology and RV function are central to risk stratification and surgical planning. Cardiac MRI and 3D echo provide complementary insights, especially in complex or borderline cases. Early and tailored intervention improve outcome, particularly when guided by comprehensive imaging, and ongoing follow-up is critical due to the progressive nature of RV dysfunction and arrhythmia risk. So we can say in a more philosophical way that in Ebstein that the tricuspid valve is not just a valve, but maybe a window into the health of the whole heart. Thank you.
Thank you very much, Andrea. Beautiful talk, beautiful images. We're going to leave questions to the discussion, depending on time at the end. And so I would like to invite Dr. Lisa Hornberger up for the next talk on the left ventricle in Ebstein's and left heart function. Mike introduced Lisa this morning, but I'll just give a personal comment that I think, Lisa, you've been a mentor and a role model ever since I was a fellow, when I first saw you when I was at Stanford as a fellow, and Lisa was at the time in San Francisco. So we've known each other for many years. Go ahead, please, Lisa.
Thanks, Mark, except for it makes me feel old. Okay, I'm just putting it out there.
I'm feeling old enough myself.
Okay, there you go. Thank you. So moving on from the pathophysiology that we talked about a bit earlier, and you've already heard a bit about the left heart, that's kind of the focus here. And I just have to say that I am presenting CMR data, and I apologize, it's not really my area of specialty. My area is echo, but in fact, there's a lot of data that's come out that has been largely CMR, and I think actually that is a better modality in looking at the left heart in our patients, at least later in life. So why study the RV and the LV? We sort of discussed it a little bit earlier. Well, firstly, there's myocardial disease of the LV that's been reported that includes a non-compaction. And yes, more recently, people have questioned whether this is real disease, reported anywhere from 5 to 30% by echo with a lower incidence in MRI. But some of our patients actually have genetic cardiomyopathies that are genetic mutations that are in keeping with things like MYH7, in keeping with non-compaction, dilated cardiomyopathy, hypertrophic cardiomyopathy. So some of our patients actually have underlying genetic conditions that potentially would give them a predisposition for myocardial dysfunction. Also myocardial fibrosis, we're going to talk about that. That is probably secondary to the hemodynamic lesion, especially long-standing. As mentioned earlier, in severe Ebstein's, the LV must function as a single ventricle, so we need to understand the function of that part of the heart in the context with more severe Ebstein's, and some have suggested LV dysfunction is the most critical contributor to congestive heart failure in adults, and certainly it is a contributor to the fetus and neonate who gets into trouble. So can't talk about the Ebstein's LV without talking about left ventricular geometry, which was one of the first recognitions that the left ventricular geometry was wrong was by your very own Lee Benson here out of Sick Kids, where they reported an abnormal shape of this left heart as a consequence of RV volume load and the atrialized RV. And in fact, others have gone on to describe reduced sphericity, which is basically taking your four-chamber view, the short axis over the long axis, and of course you get this bowing of the ventricular septum into the LV that reduces its width. And then also greater eccentricity in which you take a short axis from echo, this is echo-based numbers, and you take the plane parallel or the distance parallel to the short axis of the ventricle over D1, which is really from the septum to the free wall. And that, of course, becomes smaller and smaller in some of the most severe Ebstein's. So this is due to atrialized RV, due to RV volume load, in the presence of tricuspid and pulmonary insufficiency and RV dysfunction. And guess what? It's a feature in all ages, especially in more severe disease, and certainly different than what you would normally see in a normal LV that has a more concentric appearance in its short axis when the pulmonary vascular resistance is normal, and a little bit more spherical with a wider diameter in the long axis. So these are kind of basic things, and we've talked about how much of spectrum Ebstein's is, from milder versions where the left heart has pretty normal geometry to versions like this where that does not look normal no matter how you slice it. So when I looked at the literature on data on LV function in Ebstein's, interestingly enough, it's been mostly from the last decade that people have become very, very interested in this. I think as we see the adult population developing heart failure and people started looking more and more beyond the right heart. Most represent smaller single center cohorts, mostly data from the adults and to a lesser extent older children, likely reflecting less severe disease, in fact, not what we've seen in the neonate that we're now getting through and in the fetus. So positive data in infants and younger children, and largely based on CMR, as I mentioned, with less data, in fact, on the use of echo, and then largely focused on systolic function and mechanical dysynchrony or dispersion. Mark will be happy because he wrote a editorial to one of our previous papers that related to the fact that maybe dispersion is a better term. So with respect to echo versus CMR, how do we evaluate it? Well, the problem is, look at the left heart. It is a mess. And for shortening fraction, regional wall motion abnormalities make sampling a challenge and impact the measures that we're getting. And then echo-based shortening and ejection rely on normal LV geometry, which isn't present in the moderate to severe Ebstein's. And so with that, we really have to be cautious in how we interpret all of this. Interestingly enough, in the neonate, we do see findings that are concerning based on echo, and some of those kids are just way too sick to be trying to get them to an MRI suite. But I think strain and CMR are probably a bit less impacted by your altered geometry and maybe a little bit better for our assessments of function. This is an example, or this kind of provides some evidence for it. This is out of the Mayo Clinic. They looked at over 670 Ebstein's adults ages 25 to 49 years by echo. And they found those with low global longitudinal strain, irrespective of what was going on with their measures of ejection fraction for the left heart, demonstrated worse transplant-free survival. It looked pretty much the same whether you had low or normal EF. And the lowest cardiac index, GFR, the highest NT-proBNP, and greatest heart failure symptoms, suggesting maybe echo-based assessment of EF may not be so sensitive to really identifying pathology. And this actually study showed this further, but also gave us a bit more insight. This is Gupta et al., and this is out of the Pittsburgh group with the De Silvas, where they looked at pre-op CMR and echo in 35 older kids in a more recent era. And they showed clearly the Ebstein's patients had smaller LV and diastolic volumes in keeping with an underloaded LV, along with, of course, bigger right ventricular end diastolic volumes. But overall, didn't find big differences in EF in their experience, LV-EF by MRI, and in strain. So that was the overall cohort. But when you teased it out, they had just over half of the Ebstein's patients had EFs that were not normal, and this was by MR. And of those 18 that had abnormal EFs, only 2 of them were picked up by echo. So echo is probably not the best way, and likely because of the differences in geometry of the heart, and that MRI may have has a bit better chance of getting it right and getting better data. So those with low EF, though, I thought this was interesting, versus those with normal EF by CMR had bigger right hearts. So this was likely the more severe end of the spectrum. And they did find in this cohort a smaller or worse circumferential and longitudinal strain data. So they were lower in this group of patients. And in fact, they showed clinically there were findings suggesting they were sicker patients, including the need a longer period of inotropic support. They had a sort of tendency towards longer length of ICU stay and certainly longer length of hospital stay. So what about fibrosis? So we're going to get back to a little bit of some of the findings of that same study that I thought was good. It was one of the most recent reports and a fairly good larger experience. This is out of China that I thought was actually quite interesting. And there's also some data here from sick kids that I'm going to show you from Mike Seed's group, where they looked at largely, again, adults. And a lot of this data comes from adults with only 7 patients out of 44 ages of 10 to 18 years, so a little bit older children. And they did late GAD enhancement, and they also explored LV extracellular volume proportion of ECV. Again, they showed that the LV is underfilled and it's small. They showed that the EF in their cohort was actually somewhat reduced relative to their healthy controls, and LV mass is reduced in this patient cohort. About a quarter of them had focal fibrosis, and most of this was on the RV side of the septum. Okay, so that's where it is, not so much in the LV. And this focal fibrosis was associated with greater Ebstein severity, so greater displacement, greater right to left heart volume ratios, as well as lower systemic oxygen saturations and higher New York Heart Association class, so probably more severe disease and certainly more symptomatic disease. And then when they looked at extracellular volumes, which is a surrogate for diffuse interstitial fibrosis, they found it to be significantly greater in the Ebstein's patients, with almost half having values that are above their healthy, normal individuals that were part of their control group. And this increased extracellular volume was associated with greater focal fibrosis, shown in these dark boxes. So this is global extracellular volume. This is LV septum and LV free wall, was associated with lower LVEF, was associated with greater tricuspid valve insufficiency and New York Heart Association class. So this fibrosis, that's likely diffuse interstitial fibrosis in these older patients, seems to relate to more severe right heart disease and ultimately more severe left heart dysfunction. And this was the data from the folks here at Sick Kids, again, with Mike Seed's group, where they looked at kids of 12 plus or minus 3 years. And even here, they show focal RV fibrosis in about 16%, not quite as much as in the older group that was presented by Yang and colleagues. And they found 40% to have high extracellular volume, in keeping, again, with diffuse fibrosis. And they used another measure, and this is high average T1 times, and they found this in 33%. And so these were clearly significantly greater than what they saw in the controls. And again, they suggested this was in keeping with diffuse fibrosis in children. And again, they're kind of older children. They're not the neonates, so we have to look at that. They further showed that average T1 time correlated with Ebstein severity index. So the greater the time, the greater the Ebstein severity index. It's a bit like a Cellamar, but they use volumes as opposed to a planimeter two-dimensional image. And again, in severity, they also showed this to be true of the extracellular volume, to be correlating the greater the extracellular volume or fibrosis to correlate with Ebstein severity. They showed the T1 times also to correlate with right lung volume index, again, more in keeping with that Ebstein severity, and it to inversely correlate with O2 saturations and VO2 max. And this is just showing you O2 saturations. And this was also true of extracellular volume percent to correlate with O2 saturations, as well as VO2 max. And then finally, both of these findings of diffuse fibrosis correlated with echo-based global circumferential strain. So worse strain with greater fibrosis. So this is in a relationship. There's greater fibrosis among those patients that have more severe disease. How much the fibrosis actually contributes to the dysfunction is not entirely clear, or whether it's an association. And then folks have looked at desynchrony or synchrony of the left ventricle in older patients. This was a nice study out of Germany looking at 3 different CMR mechanical desynchrony measures. They showed, in fact, that their Ebstein's cohort shown here all had evidence or had significantly abnormal synchrony of the left ventricle or mechanical synchrony. And they further showed that this desynchrony or this dispersion, mechanical dispersion, to be related to worse New York Heart Association symptoms. So the greater that desynchrony, the worse the symptoms, the greater the desynchrony, the worse the NT-proBNP, and also showed EKG measures of desynchrony with greater QRS and QTC duration with all 3 values. So they had this relationship. And finally, again, with a sort of gross severity index of right to left heart volume, they showed this to correlate as well with LV desynchrony. So LV, mechanical desynchrony or dispersion, relates to Ebstein severity. This is that interaction between the left and right heart, where you have right heart pathology that is worse and worse and worse, and you start actually impacting your left heart function in ways that include your systolic function and your ability to contract synchronously. So what about the neonate? And this is, I alluded to a little bit of this with my earlier talk, we had put together data looking at preoperative patients with Ebstein's. Most of them were Ebstein's with a few tricuspid valve dysplasias, because in fact, you'll see that our findings suggested not a lot of difference in their preoperative left heart function and preoperative physiology. But we had 32 newborns studied at 48 hours by echo, and we showed decreased LV diastolic volume, and we used a Z-score for this. We showed measures of LV function, LVEF by bullet, and LV fractional area change to be reduced in our Ebstein's patients. We also showed, of course, the eccentricity to be increased and sphericity to be decreased in our Ebstein's patients. But additionally, we found the combined cardiac output index, and these were the whole gamut was reduced in our Ebstein's patients. E-wave velocities were reduced in Ebstein's. They don't fill the same way as our control patients, and we also looked at PAIVS. And our A-wave was the same. And then finally, mitral valve inflow time was short in our Ebstein's patients, and LV ejection time short in the Ebstein's patients. So not very healthy left hearts in the context of really bad right heart pathology. And in fact, interestingly enough, we didn't find a big difference between those with forward versus lack of forward pulmonary valve flow. We thought that was kind of interesting. What was most important, I think, and similar to what we were seeing in the fetus, is that we showed significantly decreased global circumferential in many of our patients strain, but not longitudinal strain in both those with and without forward pulmonary valve flow. So you see this R2, this one's with forward, this one's without forward pulmonary valve flow, and this is our global circumferential strain. And we showed segmental circumferential strain to be decreased in all segments for those without forward pulmonary blood flow. In fact, most of them were abnormal in those with forward pulmonary blood flow. So this is, an LV that's not a very happy LV with what's going on with that right heart. So what about fibrosis in these in fetal and neonatal patients? Well, this was one study that Bob Anderson was involved with or spearheaded that was published a number of years ago. And I thought this was interesting because while there have been reports of fibrosis in the left ventricle of neonates and young infants, in fact, they looked at 24 fetal and neonatal Ebstein's cases with demise. It included tricuspid valve dysplasia, but more of them had Ebstein's. And 23 of the 24 had no interstitial fibrosis. There was only one that they found interstitial fibrosis, and that was a fetus that had also pulmonary valve stenosis, so outflow obstruction. 6 did have some mild RV endocardial thickening with LV endocardial thickening in 2. And they said overall, the fibrosis, we would say that fibrosis may not be as such an important contributor to LV dysfunction in early life and is likely an acquired condition with abnormal hemodynamics long term. So then we also looked at desynchrony or this dispersion concept of this sort of chaotic LV dance in the context of Ebstein's. I used to like to call it a dance. And looked at this in the short axis plane, particularly, so looking at circumferential strain desynchrony, using both a novel measure of this as well as the time to peak strain deviation, and showed clearly differences in our Ebstein's patients with and without forward flow through the pulmonary valve relative to controls. When we correlated that or looked at relationships with eccentricity, we found there to be a relationship that the greater the eccentricity, so the more abnormal that geometry is, the greater the desynchrony we saw. So that's kind of a surrogate measure you could think of for the possibility of that desynchrony. And what was most interesting is that our non-survivors, and we did have a few non-survivors, even amongst those that we pushed ductal closure, but very few. You see that there was greater eccentricity index were found among non-survivors, greater circumferential strain, dysynchrony or dispersion, mechanical dispersion, and time to peak strain deviation. And these are actually showing you those open circles are ones that patients that died. So the greater the dysynchrony or the greater the abnormal function of that left ventricle, the worse outcome, with only 50% survivors with a circumferential strain DI of 0.1. And when you were above 0.2, we only had 33% survivors. And maybe this is something to be looking at when we're tailoring who gets the STARNs, who doesn't get the STARNs, because in fact, we had patients who died, weeks out after a ductal closure who were not doing well with poor function. And then we had a trend towards reduced circumferential strain. So something that is really worthy of further investigation. So finally, just to touch on a couple examples of what happens when you do have repair, the cone repair, which is an amazing technique. Obviously, I think this is really nice data out of Boston that looked at what happens following cone. They had patients that had a cone repair at a median age of 16 years. And they did pre and post-op CMR within about a 2.8-year period. So this is relatively early after the cone. They showed reduction in TR, of course. They showed a reduction in end diastolic volume and stroke volume of the right ventricle, as well as RV mass. What they didn't see was an improvement in ejection fraction, but that might take time. You know, you're talking about RVs that have been volume loaded for ages, and some of them might be at a point of no return. It's hard to know, a bit like Ortet's, who have gone on a little bit too far. So increase, and then maybe some of them have underlying myocardial disease. But importantly, they showed an obvious increase from pre to post in LV end diastolic volume. Their stroke volume significantly increased as well, and the mass, the LV mass increased. And then finally, they did show improved synchrony, as shown here, in the vast majority of the patients, with only a few not really responding in the same way. So this is probably a very important element. And in fact, I thought this was just a nice case that we had not that long ago. You look at the LV and it's sort of wiggling with that huge right heart. Again, you get the sense that there's a bit of wiggling, not as dramatic as some of them, but following cone, you see that the LV looks a bit more synchronous, and certainly that has been our experience to date. And finally, what about the neonate? This is actually really interesting stuff. We looked at those that had ductal closure, and not that ductal closure is not a good option for many of our patients, but it's an interesting and telling thing about the issues around that right heart and how it influences what's going on with the left heart. And that is when we looked at the cardiac index, PDA closure didn't really change the cardiac index. Whereas with STARNs, we had an acute improvement in the output of the left heart. And with LV global circumferential strain, again, really no change with ductal closure, but showed, and some of these had surgical closures, most of them were spontaneous closures, but with the STARNs, we saw a fairly acute and just significant improvement in strain. And this is just that example I had shown earlier with my earlier talk, with a massive TR and a plastered down septal leaflet. That LV wasn't very healthy, and it sort of looks a little pushed. And this is a baby who, after STARNs, within hours, this was a study done, and we were like, look, it's perfect. It's really not so desynchronous anymore. And in fact, when we looked at our kids who had undergone STARNs, we saw an acute improvement in dysynchrony, or improvement resolution even for some, and using both our novel DI measure as well as time to peak strain deviation. So this does, the STARNs definitely acutely improves LV function and the coordination of LV contraction, and also really provides additional insight into the importance of that volume-loaded right heart. So LV geometry and function play a critical role in Ebstein's pathophysiology, there's no question. CMR provides optimal details regarding fibrosis and function, although echo, I think, probably is still going to be the mainstay for neonatal Ebstein's, especially the very sick patients. The Ebstein's LV in older patients demonstrates reduced volume and systolic function, as demonstrated by CMR, EF, global circumferential and longitudinal strain, which is interesting because we haven't seen that in the young babies. This must be later stage disease that you start also affecting your longitudinal function, and involves focal and diffuse fibrosis in 23% and 46% respectively. In the neonate, the LV also demonstrates reduced systolic function based on EF and global circumferential strain, not longitudinal strain, as well as altered filling, but fibrosis is far less common, and maybe it doesn't play as much of a role in most neonates with this disease. So LV mechanical dysynchrony, dispersion is a key element in all Ebstein's from fetal to later adulthood that correlates with eccentricity, a finding that's worse than those with more severe disease. This interaction is clearly a major player in more severe disease and continues to be long-term. Interventions that acutely reduce the impact of the volume load in atrialized RV, as in RV exclusion and the cone procedure, improve LV filling, improve mechanical synchrony in our Ebstein's patients. So with that, I want to thank you and open up for questions.
Thank you very much, Lisa. Beautiful talk. Again, I think we'll leave questions. There is a 15-minute discussion, although we're over time, so I'm not sure how much of that 15 minutes we're left, but we'll discuss things together. Next is Dr. Rachel Wald is going to be speaking to us online. I wasn't sure if it was recorded or virtual, but I see the slides coming up. Dr. Wald trained here at Sick Kids initially, and then went on to do imaging subspecialty training in Boston before returning to the Toronto General Hospital, where Rachel is one of the adult congenital heart disease specialists, and really is a tour de force in the world of congenital abnormalities and MRI and imaging, as well as in pregnancy in adult congenital heart disease. So I'm very pleased to introduce you, Rachel, and that you're here with us, and the stage is yours.
Thank you. Thank you, Mark, for the kind introduction. I just want to make sure that my slides are showing. Are they up?
Yes, they are.
Okay, perfect. So good afternoon, everyone. I'd like to begin by thanking the organizing committee, first for including me in the program and for giving me the opportunity to speak on Ebstein and MRI, which is a topic which is really close to my heart, and it represents, I feel like, the bookends of my research career. My very first published paper was on Ebstein anomaly with Dr. Hornberger almost 20 years ago, and I have to say I was hooked on the topic ever since. So in the next 20 minutes, we'll discuss clinical and research perspectives on Ebstein and MRI, and I'll end with some new research collaborative endeavors, which I hope will have some impact on how we think about Ebstein going forward. So we'll have three objectives in the talk. The first is to understand if MRI can be used to assess anatomic features and functional characteristics of Ebstein anomaly reliably. The second is to explore how MRI can be used in our current clinical practice. And finally, we'll go on to highlight some future areas of research. So I'll begin with a case. It's a patient that was referred to me for surgical consideration for repair of his Ebstein anomaly. It was a few years ago. And at that time, he was a 31-year-old mutual funds broker, highly active in his life, very achievement and goal-oriented. He'd only had an ASD closed at age 16 years for cyanosis. Otherwise, he's asymptomatic, active on the treadmill 3 times a week, has a great exercise stress test, 14 meds. He goes for 12 minutes, good heart rate response, except that the blood pressure response was a little bit blunted, and he had a few VPBs on his Holter just occasionally. Here's his x-ray, which you'll soon see why so many Ebstein stories start with an x-ray, but you can appreciate that this heart is enlarged and it's globular. So here are the echoes that we got on this first visit to our clinic. You can see the heart is massively enlarged. You can see that there's severe TR. There's a very dwarfed left ventricle, and there's marked septal displacement of the tricuspid valve. So we went on to do what we like to do next. What I think we do best with Ebstein anomaly imaging is MRI. And we found that his functional RV EDV was 339 mils per meter squared. So that's 3 times normal. And he had moderate RV dysfunction with an EF of 36%. His LV EDV was reasonable at 88 mils per meter squared. That's normal. And he had mild LV dysfunction with an LVF of 48%. And we confirmed that there was severe TR and no significant shunt based on his QPQS. So the question I'd like to pose to everybody, and we'll get back to the question at the end of the talk, is how would you manage this patient? Would you refer to surgery? Would you continue with conservative management, or are you undecided and would like to get to the end of the talk? And I will tell you that I did present this case at an MRI conference, and I'll let you know at the end what people thought. So you've already heard about morphology and physiology of Ebstein anomaly. And I just wanted to highlight that the critical feature is failure of delamination, which occurs in the embryologic form of heart development. And that's where the inferior and septal leaflets as a package fail to delaminate. And that results in abnormal position and abnormal function of that component of the tricuspid valve. And just to remind you what a normal tricuspid valve should look like, it's saddle-shaped and has 3 leaflets. They're not cusps, even though it's called a tricuspid valve. And there are different components and characteristics of the valve. So the anterior leaflet is superior. It's usually the largest, most mobile valve part of the valve. Then there's posterior and septal leaflets, which are inferior and medial and are variable in their size and mobility. One thing just to keep at the back of your mind is not every tricuspid valve abnormality is Ebstein. There are other things on the differential diagnosis of the MRI can really help you differentiate. So you can have tricuspid valve dysplasia. You can have hypoplastic annular development or thickening of the leaflets, or you can have a congenital heart disease variant called Ebstein-like malformation and CCTGA. So how do we use MRI? So this is what we would get on a typical MRI, routine clinical MRI, cine-SSFP imaging, and we typically will see the tricuspid valve in different views. This is an axial view, this is a dedicated 4-chamber view, and here you can see the tricuspid valve en face. We know, though, for Ebstein anomaly that we're going to have to look at the valve in more detail, and the most challenging valve to delineate is the posterior valve. So sometimes we'll do these additional views in a normal exam, or, for instance, for ARVD, and every tetralogy of flow exam, we'll do these complementary views, which we call a 2-chamber view and an inflow-outflow view, and that gives us a more comprehensive assessment of our tricuspid valve. So we've already heard from various talks that this is a very wide spectrum of disease, from fetal life, where there's high mortality, to incidental diagnosis at autopsy, which is how Wilhelm Ebstein actually made his first diagnosis in 1866. And I just wanted to point out that despite the spectrum of disease, there are diagnostic features which we attach to Ebstein anomaly. So you have apical displacement of the tricuspid valve by 8 millimeters per meter squared, rotation of the annulus towards the RVOT, which is a really important point, and you'll see some research on that shortly. You have adherence of the tricuspid valve leaflets to the underlying myocardium, which we've heard. The implication of that, we know that there's some redundancy or fenestrations or tethering of the anterior leaflet as its own entity, different from septal and posterior leaflets. And you can also get varying degrees of dilatation of the annulus and the atrialized portion of the RV. We've just heard from Andrea that there are various lesions that can be associated with Ebstein anomaly. I won't go through them. There's left heart and right heart lesions. Just to tell you, the MRI is excellent at looking at associated lesions. Here's a little ASD occluder device. Here's a large VSD. And as we've heard from Lisa, there is a whole literature on LV dysfunction, and we know to look for LV non-compaction, which MRI is particularly good at delineating. Also, after intervention, we often will look to MRI. It gives us some very good resolution after tricuspid valve replacement. It could be prosthetic, biologic, or mechanical after your Glenn shunt. And sometimes we don't do so well with MRI if you have coils. This is a patient of mine that had a Fontan after severe Ebstein anomaly, had some coils, could not get good resolution on MRI, so we went to a CT. So just to keep in the back of your mind that MRI is not good for everyone. So I wanted to take a moment now and again at the end of the presentation to talk about guidelines. So a lot of ACHE management is directed by guidelines. These were the earliest published guidelines around 2008. And I thought it was very interesting when these guidelines came out that there was a lot of mention of cardiomegaly on an X-ray. And just a general assessment of RV dilation dysfunction. Those are the AHA 2008 guidelines. In 2010, the CCS came out with guidelines, which again talked about a cardiothoracic ratio of 65%. So just looking at an X-ray and looking at the cardiac silhouette and getting an index of heart size. And the European guidelines were actually quite similar, again, focusing on cardiomegaly on X-ray. And we knew at that point that there was a large literature of how you could use MRI in different lesions, maybe not so much in Ebstein. But I thought that there was a sort of a primitive approach to put a cardiothoracic ratio into your guidelines when we know that you can do all sorts of things on MRI. You could look at heart size, function, tricuspid valve, displacement, shunt fraction, and that led us at the Toronto General to start to think about how we could understand MRI a little bit better. Around the same time, we were pretty convinced by several publications, I've just chosen a couple, that there was poor correlation between echo and MRI. So echo does not give us a really good sense of what we find in MRI in terms of ejection fraction. In this study, only the global longitudinal strain had a weak correlation with MR-derived EF. So really not a lot in the adult echo world that you can get on an Ebstein study for function that's reliable. And this is a really nice prospective study that demonstrated that if you did a prospective study of Ebstein anomaly patients that had TEE and MRI, that MRI was actually the best modality for RV size function and really gave the most reliable information about the posterior leaflet, and that was based also on intraoperative findings. So I think based on a variety of imaging modalities, and we are in the area of complementary imaging, that MRI really is the imaging modality of choice for Ebstein assessment rather, and this is what we would do on MRI. Our protocol begins with localizers. We do a lot of cine SSFP imaging and all sorts of views, axial, short axis, and the various RV views, which I showed you. We'll do an angiogram really to look at the outflow tract and pulmonary arteries. We'll look at shunt fraction. And I think now in the more recent era, we're doing scar assessment by late gallium enhancement for replacement scar, as we heard from Lisa, and as well T1 mapping for native T1 values and ECV, as Lisa showed us in her earlier talk. And once you get all those values, you actually can put together a pretty comprehensive anatomic and physiologic report for your patient with Ebstein. So around 2010, we began to be interested in how to use MRI, and we knew that MRI could give you very different views of the tricuspid valve. So the axial assessment on MRI could show you very nicely the valve attachments, and the short axis view, which is our typical go-to view for function, would show us more of an on-fast view. So we had a fellow with us, Sergei Yelenetsky, and we decided just to look at the difference between MR measurements in different views. And I'll point your attention to the data on the left. So we just did a small population, 32 adults, and we had 3 interesting findings from the study. The first was that we demonstrated how you could do contouring of the right ventricle and how you can really show what the atrialized right ventricle is. This was not included in the paper, but I will say that we sat down with Bob Anderson and he helped us to develop a morphologic approach to our contouring. We found that the axial views were more reliable than the short axis views, and that was interesting. As cardiologists rather than radiologists, we usually would go to a short axis view, but in this case, axial was the better choice. And the other really striking finding was that these ventricles were either normal or large. They weren't small in terms of the functional RV-EDV. And we thought, well, maybe this is because we have a small patient population. And the next year, a German group came out with the same findings, similar size population, similar ages, similar RV-EDV. So we felt that actually these RVs in the older adults were accommodating to chronic TR and were actually getting larger. And that was really a new finding. But then we wanted to understand how do the MRI findings relate to disease severity. And you've seen already the Selmayr Index published in 1992. And this is the index, which is really a proxy for severity of Ebstein anomaly. And this is an image from that first paper that I wrote with Dr. Hornberger. Thank you for mentoring me along that pathway. I think that your first paper is like your first baby. You really have a special place in your heart. So this was a paper on the circular shunt. Doesn't really fit with this talk, but actually had some nice images. So we looked at different ways to quantify severity of Ebstein anomaly on the MRI, and we wanted to understand how that related to exercise capacity. So this is a paper that one of our fellows wrote with us, Daniel Tobler, and he looked at associations between all of these MR measurements that you can get on with Ebstein anomaly and exercise capacity, and he found in his multivariable model that the only independent predictor of peak VO2 was the atrialized RV-EDV, so that volume of that atrialized portion, which is, again, a marker of Ebstein severity. Then subsequent to that, this paper came out. I looked at different ways that you could look at severity on MRI, and they actually put out different indices. So there was a Cellamar index, which I've shown you. They coined the index from our paper, the Tobler index, and then there was these different Hosch indices, which really look at ways of either looking at the total right heart or portions of the right heart and indexing those to the left ventricle. This paper did a lot of different correlations between MR measurements and clinical values. So they looked at these different indices and these different clinical values. So here I've underlined in red all the correlations which were moderate or better. But actually, if I restrict the correlations to the ones that are actually strong, 0.8 or 0.9, it's only these two in the Tobler index. So it was the BMP and the TR fraction that related to our index. So there is a correlation between what you can do on a risk score of severity based on MRI and what you can correlate that with based on clinical indices and general markers of size, function, and extent of TR. And just to be complete, I wanted to briefly mention the study from Boston, which shows the relationship between right heart size and function and ECG parameters. And that's suggesting that there could be electromechanical associations between what you see on ECG and what you find on MRI. So now I want to look at some of the papers that look at outcome in the unoperated state and the operated postoperative state. This is, I think, one of the best papers. It looks at RV and LVEF, and it looks at the associations with MACE. And you can see on the panel on the left that if you have both RV and LV dysfunction, so RVF less than 41%, LVEF less than 51%, you have substantially worse survival than if you had either RV or LV dysfunction. And that's a MACE event that was VT, heart failure, transplant, or death. And then these authors, which is the group from the Brompton, Sonia Bebenarian's group, they looked at time to first onset of atrial arrhythmia. And in this model, they looked at larger RV to LV ratio and greater extent of leaflet displacement. And if you had both of those factors, you pretty much would go on with a very high certainty to have an atrial arrhythmia. I think this is one of the most interesting MRI papers to come out in recent years, and this is a paper from Marina Hughes from the UK. And what they looked at was just 26 patients, and they looked at valve tension pre-post cone procedures. This is 26 patients, and they demonstrated that the larger Ebstein valve rotation angle greater than 60 degrees was associated with valve dehiscence, and other factors associated with valve dehiscence were older age, a more tethered anterior leaflet, and smaller preoperative volumes. This is a follow-up paper from the same group, again, focused on patients pre and post cone. There are more patients in this cohort, but fewer patients with MRI data because they looked at pre and post pairs. And they found that post cone, you could reliably see that there was an increase in left heart area, no change in RV or LVF, and there was a sustained decrease in TR fraction. This is a paper that you've already seen from Lisa, and I won't go into it in too much detail, but just to demonstrate that although you may not see a change in LVEF or RVF, as these papers are showing, that you can see better LV performance. So you can see an increase in the filling, and you can see better synchrony in terms of the LV contraction. You can see changes in the basal septal circumferential strain, even if you don't see it in the classic global longitudinal strain. This is the final topic. I'll show you. It's a hot topic, and you've heard about it already from Lisa. I'm going to show you two papers related to fibrosis. So this is a paper from here, sick kids, 12 patients, 12 controls, and diffuse LV fibrosis as measured with T1 mapping. So native T1 and ECV those values were higher than controls and were associated with clinical findings of desaturation and impaired exercise capacity. And I think this is a very important study. When it came across my desk, I really advocated that it should be published because it actually looks at the relationship between histology and imaging, and it correlates patients that had Ebstein anomaly, several of whom that died, and they looked at what the MRI findings were, and they related the MRI findings to the histologic findings. And they found that not only was LGE prevalent and those that died, but it was associated with an increased risk of mortality. So you can see if you had LV, LGE, your risk of mortality was a hazard ratio of 6, and they attributed this to late gadolinium in the lateral and mid-wall segments of the LV. So now let's go back to the guidelines. This is where we're at in 2025. So we've made some progress, maybe not enough. We've taken out the chest x-ray, but now we have a vague allusion to LV and RV measurements on MRI without actual values. And this is the AHA guidelines. They say that we should be looking at intervention when we have RV systolic dysfunction. Here are the European guidelines on the right. There's no mention at all of MRI in their tabular format, but in their supportive text, they say that MRI could be helpful. And this is what we put together for the CCS guidelines, that you should think of intervention when you have RV dilation and dysfunction. So now we are looking forward to the publication of the AHA guidelines coming out in 2025 summertime. They're embargoed. I can't say a lot about what will be in them, but I think it's safe to say that there won't be many surprises as we don't have a much expanded evidence base for MRI measurements and outcomes. So here, back to our case. The question is, would you offer surgery for this individual? When I asked our MRI audience at the SCMR, hardly anybody put up their hand. We actually did offer him surgery. And we did a cone procedure, and this is the echo that we got after his cone procedure. He still has a concerning looking RV. We went forward for an MRI, and you can see here his pre-cone images are on the right and the post-cone images are on the left. So those were the values that we had going in: severely enlarged RV, RV dysfunction, LV dysfunction. And afterwards, although we saw an improvement in LVF, we still have significant RV dysfunction and significant RV dilation. So although our patient is actually quite happy in himself, I think he still has a guarded outlook. So just in summary, I think we have a bedrock of knowledge. I think we know a lot in 2025. We know that MRI can provide comprehensive anatomic and physiologic data. We know that the functional RV in adults tends to be normal or enlarged. Axial imaging is better than short axis imaging, that MR measurements relate to a variety of clinical values like BMP, QRS duration and fractionation, CP parameters on exercise studies, that RVEF, LVF, and LGE are associated with adverse events, and that the CMR data pre-post cone procedure are sparse but promising. But we have a knowledge gap, and I think that we need to know more about how serial MRIs can help us. I think we need to know more about how MRI analysis can help determine optimal timing for surgery in terms of reverse remodeling and improvement in clinical outcomes. I think there's going to be a lot more literature about serial fibrosis assessment and whether that can improve outcomes and whether we can offer targeted medical therapy. So just a brief note that Osami is Hanjo, he's leading a big collaborative multi-center study across Ontario using some TORCH data. I think that as I look at practice patterns and the impact of different surgical strategies, we're going to be using MRI to understand how practice is changing and how outcomes are improving. So what does the future hold? I think we're going to have a better understanding of the clinical significance of volume and function in terms of actual measurements and interval change. I hope to know more about the frequency of MRI studies. I think we're going to identify thresholds for intervention. And I think we're going to use MRI more pre and post-operatively. I think this is a very prescient commentary that was published, and it states, it is time to incorporate magnetic resonance studies into every long-term post-operative protocol, and that's from Dr. Vanderlaan. And this hot off the press paper from the imaging group here looks at ways to use MRI to plan preoperative strategies, and the signature lesion that was chosen in the graphical abstract is Ebstein anomaly, and that's Dr. Lamb's paper. So that's all I had to say, and I think we'll probably have questions at the end. Thank you.
Thank you very much, Rachel. Very comprehensive, excellent talk. While I'm setting up, just to give a few comments, we are going to go a bit over time because we have kind of an informal wine and cheese afterwards. So we're going to bite a little bit into that. And so can I ask the two speakers that are Andrea and Lisa to come down in the meantime, because after I'm going to try be brief, although those that know me, I always go over time, so I apologize ahead. I'm just going to just expand, I think, on what predominantly Lisa was talking about. Just see, get this up. So mirroring the screen. So let me just go back to the original format. All right, okay, is that seen on that? Yeah, so this is coming on online as well. So I'm just going to, for a few minutes, just talk a little bit. And as I say, I don't think there's anything new in what I'm going to say from what was said through the day and especially in the last hour. But I actually think preoperatively, when there's severe Ebstein anomaly, I don't think we can say very much about right ventricular function, maybe the anatomy, for various reasons that I don't want to go into now because of lack of time, but it's extremely difficult, and especially when you've got severe tricuspid regurgitation, any motion or shortening of the chamber can be affected, of course, by the ventricle ejecting backward into the atrium. But we've really been very, very focused on the right ventricle. But as Lisa showed you, this really seminal paper, I think, from Lee Benson almost 40 years ago now, really brought to the attention for the first time that I could find at least, that the left ventricle is compromised in Ebstein's anomaly. And as we're learning in many diseases, it's not only about the ventricle we think is predominantly affected, the right ventricle in the case of Ebstein, but it is always almost a biventricular disease. But this and other literature that you heard about in this session highlighted the compression of the left ventricle. But I don't think it's the compression alone. It's certainly important, but it's not the compression alone of the left ventricle, but it's when these interactions happened. And a few years ago, we undertook quite a detailed study to look at septal motion, right and left ventricular events, and the timing of events in healthy controls. Up here at the top on the right, the mouse doesn't show up, but the top right diagram and the bottom right diagram is the Ebstein's anomaly. And what you can see, I'm sorry, I don't have a pointer or a mouse, but what you can see in the Ebstein's is not only is that compressed, meaning the septum is towards the left ventricle and the eccentricity indices that Lisa showed, but you can see there's a very sharp leftward displacement of the septum, be it the ventricular or the atrialized interventricular septum, into the left ventricle in early diastole. And if you look at the M mode carefully, you can see, if you look at that first cardiac cycle, those two bright lines, that septum is displacing into the mitral valve at exactly the moment that the mitral valve is opening. And we know that especially in children, that rapid early filling is crucial for what the left ventricle is going to get as input. So not only now do you have poor antegrade flow from a right ventricle that's struggling to eject antegrade because of TR, because of right ventricular dysfunction, because of everything that you heard, you have poor filling of the left ventricle from that antegrade flow, which is left ventricular preload, and then as the mitral valve opens, you have the septum slamming into the left ventricle, almost like someone punching you in the face as you try to come towards them, if you will. And so this impairs left ventricular filling very, very significantly. And we're going on now in an automated fashion, working with Bart Bainen's group in Barcelona to automated analysis of various types of septal motion. You've heard of the heterogeneity in Ebstein's anomaly. There's heterogeneity in everything you look at, and you see different septal motions, different atrialized septa. And then this all affects, as I said, left ventricular filling, as Lisa highlighted in her talk. In fact, we see very, very abnormal and different patterns of mitral valve inflows that I'm not going to get into now, highlighting not only impaired systolic function of the left ventricle, but highly impaired diastolic filling and diastolic function. In fact, when we put this together by machine learning and we look at the Doppler of pulmonary arterial flow, so right ventricular output, and this is in older Ebstein's patients. So these are adolescents and young and adults. You can see here, so sorry, it's children, adolescents, and adults. You can see that while there wasn't any difference in the Doppler peaks and in the timing between Ebstein's and controls, to my shock almost, there is significant difference in the aortic outflow between Ebstein's and controls. So left ventricular output is abnormal and was associated with exercise intolerance and other parameters as it was in the first study. So we're putting this together now with the outflow Dopplers, the inflow Dopplers, and the septal motion and clinical characteristics in machine learning algorithms. And I'm not going to show all the data because I just wanted to highlight a few things. But if you look at the cluster of patients with Ebstein and you take a spectrum of these patients from -2 standard deviations to +2 standard deviations, from green to orange over here, the worst patients, those here at +2 standard deviations, are those that have the worst aortic outflow Doppler. They are the worst exercise capacity, and they are also the oldest patients in the cohort. And those are also the patients down here on the left bottom of the screen that have the worst ventricular interaction. So that is the septum displacing immediately into in early diastole into the left ventricle. So this has at least associations, and we might get to a stage where we can say causality eventually, but this is significant in terms of how these patients, their clinical status and their exercise capacity. I'll also say that when you look at other machine learning modes, so I didn't bring the slide here, you see a group of patients of exactly what you, Dr. De Silva, talked about this morning, of increased pulmonary vascular resistance that then impact their exercise capacity. And they're also a group of older patients. So we see this in the simple Doppler and M mode patterns. So I think we need to get to a stage where we are saying, well, this patient has increased pulmonary vascular resistance even later in life. This patient has dominant interventricular interactions, and this patient has predominantly RV dysfunction or other factors that are then determining their clinical outcomes so that we can be more specific in what we're doing. Remember that the right ventricle is helped in normal physiology, almost 50 to 60% of its ejection from the left ventricle. And so when you reduce left ventricular efficiency and function, you're automatically further decreasing right ventricular efficiency and function. And then, as was mentioned, this is further impacted by abnormal electrical conduction, so right bundle branch block type patterns that then cause electromechanical dyssynchrony in the right ventricle and in the septum that is shared between the ventricles. So that probably also impacts left ventricular function as well. I think it's different from the left ventricular mechanical dispersion that Lisa talked about. That probably has a different etiology, but it certainly impacts both the septum and the right ventricle and is associated with right ventricular dysfunction and with exercise capacity, at least statistically in our study. And so these, as you've heard now many times, and I'm glad this was highlighted today, the interventions that we do, be it through tricuspid exclusion procedures or be it through the cone operation, really reduce these interactions and help integrate flow through the lungs to fill the left ventricle and reduce the impact of that abnormal septal motion on the left ventricle and allow the left ventricle to fill hypertrophy and become an efficient ventricle. And really the message, I think, across various pathologies and especially in Ebstein's anomaly is that it's better to have one good functioning ventricle than a bad ventricle which adversely impacts the function of your one remaining ventricle. And that's what I wanted to highlight and was so nicely shown by many lectures today. So with that, I'm going to stop speaking. I hope I stayed under 5 minutes that I allotted to myself and open up for another kind of 5 to 7 minutes of questions for any of the speakers, including Rachel, who I think is still online, although I don't see your video anymore, Rachel.
I'm here.
Okay, Andrea, maybe you can tell me through the chat, if you can just on the microphone. If there are questions from the chat, but let us start. Are there any questions from the audience from any of the speakers? Right, well, I'm going to start off with one question then, and maybe you can help me from the desk because I can't see the comments from there. I'm going to, Lisa, have you started using strain either for function, I'm talking about left ventricular strain, either for function or for assessment of mechanical dispersion of desynchrony, as you said, in routine clinical practice, or is it more still a research tool to understand the mechanisms as we're using?
Not entirely. Having said that, we've been discussing this with the next Ebstein's patient for sure, but we have not been using it routinely. We should be. There's no reason not to, and we have growing data that this mechanical interaction is actually important. And like I said, with the neonates, it was surprising that we had some survive initially, for instance, ductal closure, or have this desynchrony end up being the patients at highest risk for demising within weeks and months. So maybe we should be using this to tailor at least our neonatal approach and certainly long-term approach to older people.
Dr. De Silva? Yeah.
Question for all of you. There is space nowadays to interventional occlusion of ASD in patients like Dr. Wall demonstrate with cyanosis. In my opinion, there is no reason for that. I would just care in that patient initially, not ASD closure. Because the reason to have cyanosis that you have severe trackless regurgitation or you have a small functional right ventricle.
Rachel, do you want to answer that, or?
I didn't hear the whole question. Can you repeat it, Mark?
The reason to indicate ASD interventional closure in a patient that presents cyanosis, Ebstein anomaly.
So is there an indication to close the ASD if there's cyanosis as a presentation in Ebstein?
Well, that's certainly what happened with this patient. He was a pediatric patient, age 16, and he had his ASD closed. It is in the guidelines. It's one of the indications for intervention. But I think probably as we've evolved over time and our surgical strategies have gotten so much better, I think we're looking probably more that cyanosis as being a marker of RV insufficiency. And maybe that's the time if you have enough TR to do a full repair rather than just close an ASD. We've definitely done ASD closures over the years to get people through pregnancy without putting them through a surgery. But I think maybe a more holistic and global surgical intervention makes more sense now.
It doesn't take care of the primary problem, right? And so this patient had progressive problems because it didn't take care of the underlying.
Yeah, exactly. And I think we're sort of stuck now because we've missed the boat in a way. I don't know how much remodeling is going to have. The MRI I showed you was several years after the cone procedure, so I neglected to mention that.
Is there a question online? We're going to take 3 more questions, maybe one online. Dr. De Silva has a question. Let's take one online and then we'll go back to the hall.
Time for Rachel and for me, if we use and
So the GO score is the Great Ormond Street score, yeah?
Was that question for me?
Or anybody because we don't do use.
Either us, and Lisa's also shaking her head.
The question is whether we use scoring systems. Is that the question?
The Great Ormond Street score.
My impression of scoring systems, at least, well, with Ebstein, with tetralogy, which is the other right heart lesion I love, is they're very good in the research arena, and I think that the clinical application, we don't use it as much. And I think sometimes it's because the risk scores just are too tedious, or they have too many components and they're just not clinically applicable. So they look very good when you publish them. We don't use them actually routinely. We don't even use the angle of the tricuspid, the epstenoid valve rotation, which I actually think is probably an easy MRI measure that we could throw on, but we haven't gotten to that yet.
Second question was anywhere you would draw a line that LV function shape volume fibrosis makes it inadequate for the grown-up patient to tolerate cone repair, and heart transplant is the only solution. I would actually ask our colleagues who do cone repairs. I mean, is there a cutoff? I think we don't have enough information yet. I think there's still data to come. I think we're really just starting to understand the impact of the right heart and the left heart. I mean, like I said, most of the data is, other than Lee's paper, which was also one that I had quoted, we're still learning about this, and we're still looking for cutoffs and when it's a point of for either side, I guess.
Well, the experience we have, because we're a surgeon, of course, are the patient who has some diastolic dysfunction. See, the septum is, has a paradoxical movement toward the left, and also subdeviation toward the left. And so those patients probably has a high end diastolic pressure, and they tend to shunt to the left. I think those cases, if you close the ASD, then they tend to have low tolerance to exercise. They'll have a low cardiac output exercise. They cannot increase the cardiac output off when they have exercise. But I think there is a place. You have regurgitation too, would be another contraindication. But I think there is a limited rule of place a device in the ASD in case that you have a mild Ebstein anomaly, and during external exercise, then you have some cyanosis. So you are concerned about paradoxical embolism time, and there's no indication, or the patient doesn't want to do the repair of the valve. So in that situation, I think there's a rule. But in the other, if you have severe regurgitation, moderate regurgitation, you have severe cyanosis, even at rest, then you have to go repair the valve, then decrease or close. But I have another, when I saw first the presentation here, the echo, I saw that there's one patient that had dysfunction, and she also has a pacemaker spike. So I have seen patients with severe synchronism caused by conduction defect, and maybe the pacemaker can induce some of that. I don't know, but it's something to concern and check, because it could be caused by the pacemaker. So I thought it was interesting that one of the cases had the dysfunction. I think I recognize that patient, but and she has also a spike, and so I think to exam to diagnose.
Patients that I presented, they did not have a pacemaker, neither of them.
But yeah, it probably is a good point to pay attention to, because we're very aware of pacemaker-induced desynchrony and dysfunction. So they're so complex anyway. I know there are a couple more questions online. Unfortunately, we are over time, and I promised Dr. C that we would take a 15-minute chunk and then out of the time and then go on. So thank you very much again to all the speakers. Thank you for a very good day. And for those that I think that are in person, where are we going, Mike? To the gallery for the wine and cheese, or yeah, we're going to move to the gallery for the wine and cheese, and I don't believe that is being transmitted online. So we'll see you back again tomorrow.
Thank you. Bye.